talks will generate a good discussion, because it's really amazing how we've been using this for so many years. The tools have been available, and so few centers are using really in clinical practice SonoAVC. So let's go to Adela's talk.
Okay, good morning again. In this second talk, we will focus on how to apply the SonoAVC. And at the end, I will give you some hints of our last article published last month about the follicular output rate, on which we use the volume to calculate it. As we have said, SonoAVC is a specialized software that measures automatically the hypoechoic structures into the ovarian volume. These are the steps to apply it, and we are going to look at it at depth now. We have two variants of SonoAVC, the SonoAVC antral and the SonoAVC follicle. The SonoAVC antral is a specialized program to study antral follicles. It allows us to establish the cutoff point for an antral follicle between 2 and 8 or 2 and 10 millimeters, and we can also make groups in that range. It's very easy to apply. We have just to acquire the volume and then select volume analysis, SonoAVC antral, and press start left or right to apply the program. In a few seconds, we will have the multiplanar view and the representation, the 3D representation of all the follicles. We have to check the results. If we are happy with them, we go to the report, and if not, we have to do some post-processing work. The post-processing work in the SonoAVC antral consists on add follicles that have not been included, remove follicles that have been wrongly included, or structures that have been wrongly included as follicles, and if the program doesn't recognize a follicle, we can also add it manually. We recommend to use for the SonoAVC antral the low sensitivity, because it decreases the post-processing time. Here we have an example of the post-processing work using SonoAVC antral. We have to scroll through the volume and remove the structures that have been wrongly included, as this one that is inside a vessel. I recommend to work in one plane. For example, I normally work on the plane A, scroll through the plane A, removing and adding follicles, and at the end, you have to check also the plane B and the plane C. Once we have finished, we go to the report. In the report, we will find the total number of antral follicles, the number of follicles in each range, and the volume-derived diameter and the volume of every follicle. For the SonoAVC antral, we also start acquiring the volume. We stand still in the center of the region of interest, adjust the 3D box, as we said previously, and acquire the volume. We will see the multiplanar view, and we have to select again volume analysis, SonoAVC follicle, and start left or right. And in a few seconds, we have our results. We scroll through the volume and check if everything is okay. If it's okay, we go to see the report, and if not, we have to do the post-processing work. In this case, we can also add or remove follicles. We can cut a part of a follicle. We can fuse two follicles that have been recognized separately, but really there are one only follicle. And we can also increase the overall size of the follicles with the growth function and increase the separation between follicles with separation function. In this case, we are adding follicles, and we have cut the part of a follicle that was outside the ovary. This is the reconstruction. In this case, we have a case of endometriosis. On the plane C, we see that the yellow follicle is bigger than the program set, so we add this part with add function and then fuse them using merge function. Now I will show you two examples where our experience can help to have better results using SonoAVC. In this case, it looks like a good quality of the image. So we acquire the volume, but on the multiplanar view, we have here this shadow over this side of the ovary. So when we apply the SonoAVC, the results are not very good. We can try to cut this part of the follicle that is outside, as we are doing now, but it didn't work. So we decided to get another volume, changing the position of the probe to avoid this shadow. We acquired another volume, but the shadow is still here. So what we decided to do is to acquire another volume, increasing the gain of the image so the contour of the ovary is more patterned, and now the results are optimal. This is another case where we have two big follicles separated by a thin septa. We acquire the volume and apply the SonoAVC. As you can see here in a moment, these two follicles are considered one. When it happens, it's very hard to solve it with the post-processing, so we did the same, increase the gain, acquire another volume, and now the septa is more patterned and the results are very good. In these difficult cases, I recommend you to get more than one volume or apply the program immediately to check that everything is okay, and always review the volume to check that all the ovary has been included. Once we are happy with our results, we can go to the report. This is an example of our report. If we have done this follicular monitoring manually, the follicle number 3 and number 8 would be the same because their mean diameter is 11.5 millimeters. But the real volume, the real diameter using the third diameter, and moreover, their volumes are very different, 0.6 and 0.4. So the SonoAVC saves time, it's more accurate because it uses the third diameter, has a better correlation with the true follicular volume, and can help when we have to decide if one day more could be beneficial for the patient, attending to the pool of follicles that are between 10 and 12 millimeters. Okay, for us, 2D monitoring is the past. We are now using 3D monitoring and SonoAVC in our daily practice. And what comes? I would like to talk to you a little about the FORT, the follicular output rate, and about our last article published last month on fertility and sterility. As Dr. Jean-Paul said, the most important parameters to estimate the ovarian reserves are the anti-Mullerian hormone levels and the antral follicle count, while the ovarian response to treatment is measured by the number of mature oocytes that we obtain at the pickup, and also we can measure with the number of preovulatory follicles, that are those follicles that are over 60 millimeters on the day of treatment. The follicular output rate is defined as the relationship between both parameters. It's the number of follicles over 16 millimeters divided by the antral follicle count multiplied by 100, and represents the capability of the ovary to respond to gonadotropins. A high FORT has been associated with high pregnancy rates and good embryo quality, while a low FORT has been associated with a low rate of mature oocytes and low pregnancy rates, and it has been proposed useful for planning future cycles in those patients. But this is not as simple, because one would thought that a patient with a high number of antral follicles will develop a high number of preovulatory follicles, and therefore their fort will be high. But when we stratify the patients attending to their fort, there have been shown that there is a negative correlation between the number of antral follicles or the AMH levels and their fort. So there must be something that we are missing. There may be other parameters that determines which antral follicles are going to grow. There are a few publications about these topics, as Jean-Paul said, and most of them suggest that smaller follicles between 5 and 6 millimeters are the true ovarian reserve. In our article, based on our experience that Jairo explained to you before, we defined a preovulatory follicle using volume as those over 0.7 cc's, and then use this parameter to define fort and call it fort volume. We wanted to know which parameter better predicts the outcome of stimulation. In our article, the outcome of stimulation was measured using this the mature oocyte output rate, that is the number of mature oocytes divided by the antral follicles presented at the beginning of the cycle and multiplied by 100. We wanted to know if fort, classical fort using diameters or fort volume, which one was the best to predict the mature oocyte output rate. This is the figure of our article. I'm going to put it bigger to explain it. In this side, we have the results for the IVF group, and this is the results for the oocyte donors. These three first columns are the fort values. The blue one is the fort measured manually using 2D. The green one is the fort using diameters, but using also the third diameter with the report of the SonoAVC. And this is the fort volume, using the volume to define the preovulatory follicle, as we said. And these two columns are the mature oocyte output rate. The first one is using the antral follicle count measured manually, and the second one is using the automatic antral follicle count using SonoAVC antral. Remember that what we wanted to know is which one of those is closest to the mature oocyte output rate. So we can clearly see that the follicular output rate using volume is higher than the manual one, and it's closer to the mature oocyte output rate. So it's the best to predict the outcome of stimulation, both in donors and IVF patients. We also studied the correlation between the number of antral follicles and the number of preovulatory follicles, and the correlation between the preovulatory follicles and the mature oocytes. We found a direct correlation with statistical significance that was much higher in the relationship between preovulatory follicles and mature oocytes. Using linear regression, we can predict these parameters. For example, we can predict the number of preovulatory follicles using the antral follicle count and the number of mature oocytes using the number of preovulatory follicles based on volume. So our results confirms the fact that automatic measurements are more accurate in predicting treatment outcomes that guide clinical decisions to trigger ovulation. We can offer an accurate prediction of treatment outcomes to the patient before the trigger and decide if one day more could be beneficial for her. And further research are needed to find factors that may determine the pool of antral follicles that are responsible to stimulation other than the antral follicle count, perhaps the follicular size. Thank you very much for your attention.
Thank you very much, Adela. And we'll now start the last discussion.